Good afternoon. My name is Nancy Quinn, and I welcome you to today's TSA webinar, Tic Management 101 for Parents, based on a CBIT perspective. Funding for this webinar was made possible in part by the Centers for Disease Control and Prevention. The views expressed in materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. Our presenter is Dr. Douglas Woods, Professor and Department Head, Department of Psychology, Texas A&M University. For those of you who would like to ask Dr. Woods a question following his presentation, questions may be submitted via the written question box located on the left-hand side of your screen. The question session will be moderated, and we'll try to get to as many questions as possible. Today's webinar will be archived and available for viewing free of charge in about 3 business days on the tsa-usa.org website. Finally, the last slide of this presentation contains a link to a brief evaluation. Please do take just a couple of minutes to let us know your thoughts and to offer suggestions for future webinars. And now, our presenter, Doug Woods. Welcome to you, Dr. Woods, and please begin.
Thank you. Nice to be here today. This is a little different. I'm used to talking to people I can see, but welcome to everyone that's out there. Today I'm going to talk about Tic Management 101 for parents, behavior therapy or a CBIT perspective. CBIT stands for Comprehensive Behavioral Intervention for Tics, and it's a non-drug treatment that my colleagues and I have developed over the last number of years, and it's been tested. So I'll talk a little bit today about CBIT, but I'll also talk about just general strategies parents can use to manage tics in children with Tourette syndrome. So let's talk about tic management. What do we mean when we say tic management? Well, I think it's important to understand from the beginning that there really is no cure for Tourette syndrome. There's no pill you can take that cures it. There's no surgery you can have that cures it. There's no genetic treatment that you can have that cures it. Once it's there, it's there. Now, it might go away by itself, and at times it does. As children get older and become adults, some will grow out of the disorder. But generally, when we're talking about how to manage tics, we're talking about not a cure, but a system or a strategy for managing them. All the treatments that we have right now are some form of symptom management. Medications manage the tics chemically. Surgeries alter the tics physically. And behavior therapy is another way that you can effectively manage your tics. So when we talk about successful management, what we're really talking about is successful coping. You still have the tics at some level. They might be greatly reduced, and you're learning how to live more effectively with them. So let's talk about, from a behavior management perspective, from a behavioral perspective, how would one manage tics? Well, let's start by talking about the rationale for that. Why would we even consider using a non-drug or non-pharmacological approach to managing tics? Well, here's what we do know. That everybody has factors that push and pull their tics around. Sometimes these are factors that occur inside the body of the person with Tourette syndrome. So, for example, people with Tourette's will often experience an urge to tic right before they do the tic. They'll describe it as an itch or a tickle or a tingle or a pressure. And this feeling, what we call a premonitory urge, builds up. And when people tic, that urge goes away really briefly, making the tic more likely to happen the next time the urge shows up. So the children with Tourette's get in this cycle of feeling this little urge, ticking, that urge goes away. Feeling a little tick, feeling the urge, the kid tics, the urge goes away. And the tics become stronger because they bring that urge down. Now, not every child will tell you they have an urge. Some won't feel it. Some may not be aware of it even though it's there. Some tics will have the urge, some tics won't. But many children, especially if they know what they're looking for, will find that urge, and then they'll report that they feel like they have to do the tic and that the tic takes that urge away. So that's one thing we know about Tourette syndrome and something we might be able to do something about from a behavioral standpoint. We also know that there are a lot of events in the world, things that go on around kids that push and pull tics. If you think about your own children, for example, I'm sure you can think of different situations your child walks into that makes their tics worse, or different situations that make their tics better, for example. And what we try to do with behavior therapy is to understand the factors that happen inside the child's body and outside the child's body in their environment that make the tics worse, and then try to change the environment so that we can more effectively manage the tics. And when we talk about those factors, we're talking about antecedents and consequences. So let me give you a few examples. I talked about how tics keep themselves going with that premonitory urge. So that premonitory urge builds up, the child tics, and then there's relief from that premonitory urge. And we call that reinforcement, that when you take away something that's unpleasant, the behavior that took away the unpleasant thing gets strengthened, it gets stronger, and we call that reinforcement. So that's one way that tics keep going, that we can do something about. Another way that we've said tics keep going is that situations in the environment make the tics potentially worse than they need to. So, for example, kids will tic in different places or situations. Sometimes situations will make tics worse. Sometimes situations will make tics better. Sometimes other people when kids are around other people or certain people, their tics get worse. Sometimes when they're around other people, their tics get better. Sometimes when they're doing activities like playing sports, they don't tic very much. But maybe when they play video games, they play a lot. Maybe when they're bored, they tic a lot more. Maybe when they're calm, they tic a lot less. There are also reactions or consequences to tics that can make tics worse than they need to. Sometimes children get a lot of attention for their tics. And it's not to say that they're ticking to get attention, but the attention happens every time they tic, and that can make the tics worse. Sometimes the children get out of activities. They don't have to do something they don't really want to do because they're having a big bout of tics. And so they're allowed to get out of that situation because of the tics. And in that case, that can actually make the tics happen more frequently in the future. We call that escape. So what we try to do in behavior therapy is we try to understand how the environment is unique for each child, how the factors that push and pull tics are unique for each child. And then what we try to do is to develop useful treatments that deal with both the external factors and the internal factors. In other words, dealing with both those factors that happen outside their body, the things in the environment, the activities and the reactions to tics and so on. We try to understand how those affect the tics, and we try to understand how that urge and the reduction of that urge right after they tic affects the tics. So what we're trying to do then is, once we've identified those things, we're trying to intervene in a non-chemical way, a non-drug way, as a way to bring about changes in their behavior. In other words, we're trying to teach them how to manage those symptoms more effectively. How do we do it? Well, the external factors, those happen in their day-to-day life, the environmental factors, we address those through something we call function-based intervention. And I'll describe what that is in a second. The internal factors are described through something we call habit reversal training. Right? So let's talk a little bit about each of those. In function-based intervention, what we would do as a therapist is to sit down with the family and to identify situations that make tics worse than they need to be. So we'd sit there and we would ask the family, what kinds of situations makes your child's tics worse? Does it get worse when he's in school? If so, what classes is it worse in? What is he doing during those classes where the tics are worse? How are people reacting in those classes where the tics are worse? What about at home? When are his tics worse at home? Are they worse at home right after school? Are they worse at home right before he goes to bed? If so, how is he sitting? What is his posture? What activities is he doing while he's getting ready to go to bed, for example? His tics are worse then. How are people reacting when he starts to tic a lot? And all those things we look at, and what we're looking for are patterns in the environment that trigger the tics, that make them much worse than they usually are during the day. And once we've identified those patterns, we try to change the environment, change the patterns, change the way people deal with the tics, change the way the day-to-day routine the child might have so that they come in less contact with the things that make the tics worse, or we change those situations so those situations don't have as big of an impact on the child's tics. And we teach the family how to do that. For example, we might have, let's say the child is ticking a lot in math class, and we find out that in math class he's sitting right up in front of the teacher in the front row. He gets very nervous when he is sitting in, thinking he's being seen by other people, and when he's nervous, his tics get worse. So we might do something like, maybe a better way for him to be seated in the classroom for math is to sit in the back of the class. Maybe he gets a break every 10 minutes to stand up and stretch and quietly move around. so he's not seen, he doesn't feel anxious. He doesn't have to sit for too long because sitting makes his tics a little worse. So we might change the environment that way. These are subtle little interventions that we'll do to try to bring about a more effective tic management. Many of you probably do these things already, and that's exactly what we would be trying to teach. In the function-based interventions, this is usually done within the context of the family. So we're trying to get the family to work with us to organize the child's environment in a way that is a little more tic-friendly. A little more tic-neutral, I guess you could say. During our function-based intervention, we really are encouraging the children to take responsibility for themselves and their treatment. The parents shouldn't do all the work in this. This is really the child learning how to manage their disorder, learning how to manage their disease. If you have a child with diabetes, for example, you'd want your child to learn how to manage that. They have to be independent on this. This is their responsibility to some extent. Your responsibility as a parent is to teach them those management skills. And the same thing is true for Tourette's. So we really encourage a child to take responsibility for themselves and their treatment here. And we really discourage the victim role. We really encourage the role of, accepting the fact that you have Tourette's and now you have to manage it in the real world. And that's how we deal with it. So based on that, we have a few general principles that we like to teach parents. I'd like to talk about those a little bit with you. These are general principles that we encourage all of our parents to follow because we think they help create more of a tic-neutral environment, which is really what we want to try to do. So the first general parenting principle that we have when we talk about teaching children with tics to manage their tics effectively is we ask the parent to not react to the tics. I know tics can be frustrating. I know parents look at it and they can sometimes be embarrassed or scared or frustrated, but it's really important not to react to the tics. And I mean completely not react to the tics. Not, don't ask, hey, you're doing a great job controlling your tics, or, hey, you're ticking again, don't do that, or how were your tics today at school? Those are all reactions to tics. What you really want to do is to create a very tic-neutral environment, but by not reacting to the tics. We also ask parents that they not express frustrations with the child's condition. Around the child. I know tics can be frustrating, and I know parents sometimes just kind of like, I can't take it anymore. But if you're going to do that, don't do that around the child. Sometimes you might have to go to another room, walk out of the house, scream into a pillow, I don't know, but don't express frustrations around the child. The child can pick up on that, and that usually just ends up making the tics worse. And the other thing that we really want to make sure we focus on is, your child is way more than a collection of tics, right? We all know that to some extent, but sometimes we forget because we get so wrapped up in the tics themselves. So we always ask parents to focus on the child's strengths. Don't be the tic police. The first question out of your mouth after the child comes home from school shouldn't be, how are your tics today? It should probably be, what'd you do at school? Oh, you got a B on a test? That's wonderful. Okay. The fourth point that we always try to point out to parents is that TS should never, ever lower your expectations for your child. Tourette's should not be allowed to be an excuse not to do what your child wants to do. You should never decrease what you think your child is capable of simply because of the tics. Now, the truth is, tics might affect how you do things. You might need accommodations to get things done, but you shouldn't be hindering yourself or your expectations of your child simply because of your tics. Because we have people in this world who have very bad Tourette's, but they do all sorts of things. They're surgeons, they're PhDs, they're successful actors. They do a lot of things, and the Tourette's has never gotten in their way. So we always encourage parents not to lower your expectations for your child simply because of the tics. We also ask that you keep your child mentally and physically busy. There's good evidence now that physical exercise, for example, has a very positive effect on tics, not just while you're exercising, but even after the exercise, the tics will usually be lower. So keeping your child mentally active, physically busy, those are very good things to help your child learn how to manage their tics themselves. And this should be something you should try to incorporate into your child's daily routine. Get them to understand the importance of this and have them take ownership of staying mentally and physically busy as a way to effectively manage their symptoms. Another thing that's really important is to have an established bedtime routine and make sure your child gets enough sleep. Now, I know sometimes children with Tourette's have sleep problems, but you need to work as hard as you can to try to make sure that you have a good bedtime routine, and that your child is getting enough sleep. Letting your child have a period of time where they are able to wind down before going to bed, for example, and they know that bedtime is 8:30 every night. Also, another thing is we do know that stress and anxiety often makes tics worse. So another general parenting principle we teach children is to teach parents is to remind the children to relax when they see the child becoming stressed. Now, that's how we deal with the external factors, those general environmental factors that make tics worse. But we also deal with those internal factors, those premonitory urges. We talk about premonitory urges, those feelings that come before the tics that make the tics worse, and then when the tic happens, that urge goes away, is relieved for a little bit. How do we deal with that factor, that situation, which we know tends to make tics worse? Well, we deal with those internal factors through something called habit reversal. Habit reversal has three primary components: awareness training, competing response training, and social support. So what we do in therapy is we teach the children, we first ask the children to tell us all the tics that they're doing, and then on a tick-by-tick basis, we usually treat one tick a week, for example, we run through all of the habit reversal components for that tick. So we would start by taking a tick and then doing awareness training. In awareness training, we start by having the child provide a very good description of the tick, and after they've described the tick in great detail for us, we have them sit there and practice with us in session, catching the tick in real time. So we ask them, we say, for the next 5 minutes, sit down with us, and every time you do the tick, let us know by raising your finger. If they catch it, we say, good job. If they miss it, we say, oh, don't forget, raise your finger when you tick. Practice that over and over again until the child is very aware of their tics. Now, some people get worried and they think, oh, well, if you make the child more aware of their tics, won't they tick more? In the vast majority of cases, the answer is no. What we're trying to do is get children to bring into their own awareness when the tic's happening so they can actually do something about it. So after the tic is, the child is more aware of the tic, then we teach them to do what we call a competing response. A competing response is a behavior that the child can do that physically prevents the tic from happening. Okay? So, for example, if you have a neck-jerking tic, a competing response might be to gently bring your chin down slightly and gently tense the sides of your neck, the neck muscles. And if you're doing that, you can't tic at the same time. So what we do is teach the children to do that competing response exercise, and the competing response is always a behavior, most of the time, a behavior that can physically prevent the tic from happening. We ask them to do that competing response for a minute or until the urge goes away, whenever they feel the urge to tic or when they actually do the tic. So we ask them to do that throughout the day. They start feeling a feeling in their neck like they have to do the neck-jerking tic. They have to do the competing response, gently tensing the sides of the neck and putting the chin down, holding that for a minute or until the urge goes away. And then at the end of the minute or when the urge is gone, they just go about doing their regular day. When the urge shows up again, at the same time, they're asked to do their competing response again. Now, while they're doing their competing response, we don't want them to shut down everything else. What we want them to do is continue doing, what they were doing before. We want them to incorporate the competing response into their daily activities. We also ask the parent to help out in habit reversal by doing two things. The first thing we ask the parent to do is if they see their child doing the tic that we're working on, but not using the competing response, we ask the parent to say, don't forget your exercise. And we don't say, stop ticking. We tell the parents actually to not even say the word tic. We want the parents to remind them to use the exercise. The other thing we ask parents to do is if they see the child doing the competing response correctly, we ask the parent to praise the child. We say to the mom and dad, if you come into the living room, for example, and you see your child doing their competing response to their neck tic, say good job. Praise them. Let them know that they're doing a good job managing their tics. Now, we've tested these interventions, the function-based interventions and habit reversal training. We've combined those into a treatment called comprehensive behavioral intervention for tics. And we tested this treatment for children and adults The slide you're seeing now is the copy, the face page of the paper that we looked at, the treatment's effectiveness in treating children. This was published in the Journal of the American Medical Association in 2010. The findings showed that behavior therapy is fairly effective for treating kids with Tourette's. In this particular study, we found that after 8 weeks of treatment, 53% of the kids had either no longer had tics or the tics were greatly reduced and had significant decreases in any kind of problems that tics cause. Another 25% did get some benefit from the treatment as well. And so it didn't work in about 1 of 4, perhaps. We also saw significantly reduced tic severity. We saw reduced tic impairment. And we know that even 6 months later, the treatment gains were maintained. So kids who got better stayed better. Now, we also looked at this and compared CBIT to how medications might perform, not directly comparing, but looking at the two sets of studies. And what we find is that behavior therapy works about as well as medications like Risperdal, Clonidine, or Guanfacine, but they don't have behavior therapy doesn't seem to have side effects. Now, I'd like to, we're at the time, I was supposed to go about 20 minutes and then open it up for questions, so my primary part of my talk is done, but I want to leave this by, and get ready for questions by saying a few things. Because sometimes, I only had 20 minutes to explain this, and I don't have a lot of nuance in 20 minutes. So I'd like to make sure you didn't hear a few things. Sometimes when I do a behavior therapy talk that's short, parents will hear me say one thing when I didn't really mean it to be said that way or be interpreted that way. So I want to just give you a few points at the end. First of all, don't think that because we have a tool to help manage tics in a behavior therapy, don't think that I'm saying that all children with tics need or could benefit from behavior therapy. Not all kids with tics need treatment. Sometimes if the tics aren't impairing, they're not bothering anybody, the child is happy, successful, functioning well, treatment probably isn't necessary. And also, behavior therapy can be effective, but it isn't effective for everybody. Clearly, 1 in 4 won't benefit from the treatment. And also, I don't want you to believe that just because we have a behavioral treatment, that must somehow mean that the behavior is a learned problem, or that Tourette's is a learned problem, and it doesn't mean that the child is doing things intentionally. We have all kinds of treatments for neurological disorders, and it doesn't mean that just because you can use a non-drug treatment or non-medical treatment that the disorder must be a non-medical disorder. So, for example, people who have a stroke, rehabilitation from a stroke is a non-medical procedure. It's basically behavior therapy, practicing exercises over and over and over again, and people can recover from a stroke and to a great extent because of those behavioral procedures. But no one would argue that a stroke is something that you've learned to do simply because rehabilitation is effective. And in many ways, behavior therapy is the same way for Tourette's. Just because behavior therapy works, it doesn't mean that Tourette's was a learned problem or that the child was trying to do the tics to irritate you or something like that. It's also, I described behavior therapy in 15, 20 minutes, so it sounds like it might be simple or easy to do, but it's not. It's a hard thing. It's a lot of work for the child and the family to do this. And so don't believe by just, when you hear this talk that behavior therapy is simple or easy to do for your child. We're going to... I want to make clear that even though we're talking about behavior therapy, sometimes people think behavior therapy just means, bribing the child or giving the child money if they don't tic or something like that. And you'll notice that we don't ever talk about that in here. Rewarding tics for a child for not having tics is not good behavior therapy, so keep that in mind. We don't do that as a therapeutic technique. We also want to make sure that you understand that we're not saying that your child is doing tics to try to annoy you, to frustrate you, or to get your attention. Sometimes you get annoyed, sometimes you get frustrated, and sometimes you give your child attention when they tic, and that actually could potentially make the tics a little more frequent, but that doesn't mean your child is trying to do the tics to annoy you, frustrate you, or get your attention. And also keep in mind that, as I said, behavior therapy doesn't work for everybody. So if your child tried or has tried or will try behavior therapy and it doesn't work, that's not your child's fault. It doesn't mean that the child didn't try or was lazy or didn't put in the effort. Even the best treatments don't work for everybody. So please don't hear that, if your child tries this and it doesn't work, that's somehow the fault of your child. So with that, I think I'll open it up for questions.
All right, great. And folks, remember that you can type your question into the question box and send it along. We have quite a few in queue already, Doug, so here's the first one. Can you explain again how competing response and voluntary suppression differ? It seems like you still need to voluntarily suppress in order to do the competing response.
Right. Okay, so voluntary suppression, one of the things about Tourette's is kids can always, not always, but many kids and adults with Tourette's can suppress their tics for a short period of time. Now, most children come about this accidentally. They figure out they can do it. There's usually a lot of pressure for them to suppress, either the pressure they put on themselves, pressure their parents put on them, pressure their teachers put on them, pressure their peers put on them. And when they figure out they can suppress, what they try to do often is to work really hard to not have any tics. It's like they hunker down and the tics in. Okay, that's voluntary suppression. That's fatiguing. That can wear you out mentally. That can wear you out physically, and that is not at all what we do in habit reversal when we talk about using competing responses. So remember, in competing responses, when we're using those competing responses, we're treating one tic at a time. And so we get good control over that one tic. We don't care if the child has other tics. We pay no attention to them. They just happen. We pick one tic at a time. We usually start with the most distressing tic. And we teach them how to do it in a way that doesn't fatigue them so much, that doesn't take away their attention from things. And so they aren't holding back their tics all day. They're letting themselves do what they do most of the day. But when they feel that urge to do that one tic, then they go in for a minute and work on it. And then after that, they're done, and they go back to their regular, doing whatever they do. And so it's very much less effort in terms of using a competing response relative to hunkering down and trying to stop all your tics at one time.
And on that note, then, Doug, here's a question. Can CBIT work if the child has multiple complex motor tics?
Yes, actually, I think complex tics are easier to treat than some of the very simple ones, like eye blinking. What we do is we don't try to overwhelm the child. So remember, one of the first things we'll do is make a list of all the tics the child has, and then we'll work on the one that bothers them most. And once we get good control over that, we'll go to the next one and so on. And the way we handle a complex tic is we look for the earliest part of the movement in a complex tic. So we break that complex tic down into a chain. We look for the earliest part of the movement, and then we build a competing response to stop the earliest part of that movement. What we find is that when we do that, the rest of the tic doesn't happen. So it's like that first part of the movement has to happen for the rest of it to occur. And if we block the first part of the movement, the rest of it doesn't occur.
All right. And when speaking about children, what ages are you referring to? For example, would behavior therapy benefit a 3-year-old, or should we hold off? And does behavior therapy also work for older teenagers?
Yeah, so in the big study I talked about, the one I showed the slide of, that one was done on children ages 9 to 17. Okay, so it works pretty well down to age 9. Now, we've done some other testing looking at kids ages 5 to 9, I think, or 4 to 9, and again, it works very well. Now, when you're younger, when you're 3, it would look a little different. You would spend more time focused on the function-based interventions than habit reversal. A 3-year-old would probably have a difficult time with habit reversal, but you would do other things, like so you'd try to create that tic-neutral environment. You'd try to not pay attention to the tics. You'd try to minimize situations where the tics were likely to flare up. You'd do more of those kinds of things for a very young child.
All right, and here's one. Are there any studies suggesting the effectiveness of a combination of behavioral and pharmaceutical treatments?
There's never been a study looking at whether behavior therapy works better in combination with other medications. That's a very good question, and unfortunately it hasn't been done.
How well does this work for verbal tics regarding, say, profanity?
Sure. Vocal tics, the sound tics people make, all of them are essentially treated in the same way. They're treated with what we call a relaxed breathing pattern. So the child feels that they have the urge to say something or make a grunt or a cough or maybe say a bad word, and they're taught to go into this breathing pattern. And it works as well for the swearing tics as it does for a coughing tic, which is usually quite well, actually. Vocal tics respond quite nicely to this in many cases. So the content of what they're saying, whether it's a profane word or not, doesn't really matter because it's really the same muscle action that's producing the sound in many cases. Whether it's a silly syllable or a bad word, it's really the same kind of tic. So it actually works quite well.
Someone's asking, Doug, if you can provide an example of an exercise for a common tic, such as throat clearing or noises.
So it's a little hard to do if you can't see me, but I'll try to describe it. So if you think of a throat clearing tic, how do you make that sound? You make it by usually exhaling through the mouth. So that would be an exhale through the mouth if you think about which way your air is going. What we would do for a competing response is get children to come up with a relaxed airflow. So we call it this diaphragmatic breathing. When you breathe in, and when you're breathing diaphragmatically, you breathe in and your stomach goes out, and while you breathe out, your stomach goes in. It's sort of opposite how we normally breathe. When we first teach the child how to do that sort of relaxed breathing, and then we think about the airflow. And the airflow we use is always going the opposite direction of that which makes the tic. So, for example, if you have someone who's clearing their throat, that airflow when you're making the tic is air going out through the mouth. When we do a competing response, we would never, in the competing response, air go out through the mouth. We would always have air go in through the mouth and out through the nose. Because if air on the competing response is going out through the nose, they couldn't breathe out through the nose and do the tic at the same time. We have them do that breathing pattern for a minute or until the urge to do that throat clearing passed.
All right. I hope that that helped everyone to understand, even though we don't have the visual. Just a quick note, you can go on to the TSA-USA website and see this demonstrated through a video. But right now we'll move on, Doug, with a question of, can CBIT work if the child has ADHD or OCD?
OCD, what we can tell so far, probably doesn't impact the child very much in terms of how well they'll respond to CBIT. ADHD might. If the child has a hard time doing the exercises because they're so distracted, they simply just can't do the exercises, then that would obviously make it a little more difficult for them to respond to behavior therapy.
Right. And is there any correlation between having ADHD and TS/tics? Can one exacerbate the other?
Yeah, well, we know there's just a very big genetic linkage between ADHD and tics. So we know that if you have tics, you have a much, much greater chance of having ADHD and vice versa. So there's some estimates that, say up to 60-70% of kids with Tourette's will also have ADHD. So there's definitely a genetic link. Whether one exacerbates the other, they're so intertwined in some way, it's hard to tell. So if you're having a big bout of tics, you might already have attentional problems, but if you have a big bout of tics, your attention will even get worse because you're so distracted by your tics. So that you could have that kind of situation too. And likewise, if you're hyperactive and kind of moving around a lot anyway, sometimes you start moving and then the movements start to become tics. So you can get kind of ticky because of your hyperactive movements.
All right. And we have a question that said, in the 2010 study, did you address potential factors for why it didn't work in the 1 in 4 children?
Why it didn't work? We haven't looked at all of what we call moderators or predictors of who responded and who didn't. We're still working on those data to figure out exactly who gets the best benefit and who doesn't get the best benefit from this. My general impression, though, because I did all the supervision on that study, I supervised a therapist from the 3 sites where we did it. My general impression was that when it didn't work, it had a lot to do with the child just couldn't do the exercises. They either couldn't or weren't motivated to do the exercises necessarily. Sometimes the kids tried as hard as they could and it just didn't take. Sometimes the kids, their ADHD got in the way and they couldn't do the exercise. It wasn't that they didn't want to get better; they didn't want to do it, but it was tough for them. And so I think that became probably the biggest predictor.
Okay, thanks. And how do you not react to tics, but help the child cope? For example, our son doesn't recognize what a tic is.
Okay. So I would say, for example, let's start with this. If your child doesn't know what a tic is and is not being teased, is not being affected by the tics at school, is not being harmed by the tics in any way, I would probably say, and it is like, it physically isn't hurting him or anything like that, I would probably say there's nothing to do there. Pretend he doesn't have tics and do your thing with him. Treat him like you treat any other child. And I know that sometimes that sounds strange because to us as a parent, it looks like, wow, that's so unusual looking. I don't want him to have that. That looks funny. But honestly, if it doesn't impact him or impair him, then you just don't worry about it. And I know that's easier said than done, but that's really kind of what we mean by creating a tic-neutral environment.
Do you find that IQ comes into play?
I think at a certain level it does. I think if you get a very, very low IQ, then a lot of this stuff is harder to do for the children because they have to, be able to be aware of themselves and their bodies a little bit and do some of this. And that's going to get harder when you have very low IQs. But we didn't find, actually, that IQ in our study predicted whether kids would do well or not well. In general, my impression is that kids with Tourette's have IQs on average, but I don't know if that's been, I know I've seen a couple studies that suggest that, but I don't know if that's been replicated or not.
Here's a question, Doug, regarding the effectiveness of CBIT for tics versus hypnosis.
There's very little data on the effectiveness of hypnosis. There was one study that was published a few years ago in Developmental and Behavioral Pediatrics. The study left open a lot of questions as to whether hypnosis was really the thing that was causing these kids to get better, and frankly, whether the kids really did get better. And so there really just hasn't been a lot of good data on hypnosis. Now, the truth is, it might work. We don't really know yet. That's the problem, and that's why we do the research, is to show that what we're testing as a treatment really is the thing that's making the kid better. And as far as we know in the hypnosis data, we don't have any data, strong data, to say that hypnosis is really causing any kind of behavior change in these kids. So I'm not ruling it out, but I don't think it's been really well tested yet.
All right, and this question kind of gives back a little bit, I think, to an earlier one regarding multiple complex tics, but this viewer is wondering if you found that a child can actually focus on the tic that they're working on when urges exist for other tics.
Yeah, that's a good question, but it really does seem to be easy for them to do this when they to do what was asked in the question. What we're doing is we're really kind of relieving the pressure. We really do say, look, you can take as much as you want on those other tics. We don't really care about those right now. Don't spend any mental energy thinking about those. Just focus on this one tic. And we actually think that in some cases that makes it easier for the child. They don't have as much pressure. They're focusing on that one tic.
And Doug, we're wondering here, can you share more about the decision to seek this treatment? So, for example, if a child finds the tics annoying, is that sufficient enough to seek treatment, or is more impairment needed?
No, I think that's a fine reason. If the child is annoyed by the tics, that's probably one of the best reasons. It's better than if just the parent's annoyed by the tics. Because remember, in this treatment, the child has to be involved. We're making the child take ownership of this. We're saying this is you were dealt this hand, and now we're going to help you deal with it. Okay, but you're going to have to do some work. And so if the child comes to the parents and says, I'm annoyed by this, this drives me crazy, that's the best situation we could ask for in CBIT, because then we know the child's motivated.
Okay. Is there currently any evidence of a relationship between executive functioning, primarily elements of impulse regulation and self-monitoring, and severity of TF?
I'm trying to think of any particular one study that's looked at in relations of impulsivity and tics, and generally yes. One of the ways you measure impulsivity is response inhibition. Can you kind of inhibit yourself? That's an executive function. And we do know that children with Tourette's will have greater problems inhibiting responses, holding back the likelihood of doing something. So yes, there's definitely a relationship between executive functioning deficits and Tourette's.
All right. I do want to make a note here. Folks are asking if we'd be able to get a copy of these slides. Everyone know that when this presentation is up on the TSA-USA.org website, it will also be, a link will be accompanying it where you can download Dr. Woods' slides. So you can print those and refer to them. Dr. Woods, is there an average age in which tics might disappear with or without CBIT?
Well, there's a general belief that in children with Tourette's, about a third of them will no longer have tics as an adult. Another third might still have tics, but they'll be much lower frequency, and another third will continue to have tics into full tics into adulthood. The truth is that those findings haven't been replicated enough. I still think we don't know exactly what happens long term with Tourette's. I think generally everybody understands that the tics will get better as children get older. We know clearly that the worst time of tic severity is somewhere between 10 and 14. But whether tics completely go away as adults, I think for some they sure do. For many we don't know yet exactly what happens. So I think to take some comfort in knowledge that almost regardless, in the vast majority of cases, the tics will get much better as adults. Whether they completely go away, for many, that's still up in the air a little bit.
Is there any information on the exercise in helping a child to manage their tics?
As a standalone intervention, so the only thing you do, there's not a lot of great evidence that a good physical exercise regimen alone will be helpful in getting rid of tics, for example. But we do know there's a study that just came out not too long ago looking at the effects of playing an exercise video game like Wii Fit or something like that. And it showed that when the kids were playing the video game, the tics were reduced, and that benefit actually lasted for a couple hours after the video game. So we just do know that physical exercise in general can help manage tics, but whether or not it's enough as an intervention by itself, we don't know.
And in that note, how about diet? Is there any proof that a change of diet can reduce tics?
I wouldn't rule it out, but again, I don't think there's a lot of great evidence to say that that's actually the case. Obviously, the more healthy you eat, the better you're able to control your own actions. But as far as a standalone, there's one supplement or one dietary vitamin or mineral that you must have to control your tics, not that I know of. I've not seen any good studies to say that that's true. Again, my advice there would be, eat healthy. Teach your child to take care of their body in a healthy way, and that'll be the best thing you can do in terms of diet.
All right. And, Dr. Woods, I believe this gets back a little bit more to when you were talking about tic management and parenting skills and what you do and don't want parents to take away. But, again, should disciplining a child with TS be any different from a child without TS? And that's not necessarily pertains 100% to just tic management, but it's a little broader. But would you respond to that, please?
In general, I would say no, as long as we were understanding a couple things. First of all, that we're not talking about disciplining them for having tics. We never discipline them for having tics. But what I tell parents is sometimes tics can create situations in the environment that the child must take responsibility for, and you can discipline them for failing to take responsibility. Okay, so here's what I mean. So let's say your child, has a tic where they say bad words. They call people a name. They have a name that they call somebody. And they see that person and that name just kind of blurts out. You can't really punish the child for saying that name, for blurting that word out. That's the tic. But what you can do is to teach the child that, hey, when you do that tic, the person you're saying it to, they may understand, they may not, but they may feel really bad that you said that. And your responsibility is to, A, let them know that you do this, why you do this, that you don't mean anything by it, and B, whenever it happens, you need to make sure you apologize to them and make sure that they understand that you weren't really meaning it and so on. If you don't do those things, then there might be consequences. So we're not punishing the child for having the tic. We're punishing the child, if we have to, or disciplining the child, if they don't take responsibility for the situation that tics may create. If a child, for example, has a tic where they jerk their arm out and knock the glass of milk off the table, you can't punish the child for knocking a glass of milk off the table, but you better expect that they get up and clean up the milk. And if they don't do that, or if they refuse, then that's something you'd want to discipline, because that's the part they can control. They can control if they clean up their environment. Now, I know some parents will say, but it's not fair that he has to do that. He has this disability. Well, the truth is, if you go out and you walk by a police officer and you have a tic and you reach out and punch the police officer may not care if you have Tourette's or not. You're going to want to teach them how to manage those tics effectively and the consequences of their tics when they get out in the real world. And so that's really what we're talking about when we talk about discipline.
Dr. Woods, viewers wondering, why do my child's tics change? He has several different tics that take turns each year, and how does CBIT work with this variable?
Sure. So one of the hallmarks of tics is that they switch. They come and go. New tics start, old tics fade away, and that's just the nature of the disorder. The problem in Tourette's isn't with a particular tic. It's with a part of the brain that regulates the inhibition of movement. So that part of the brain doesn't inhibit movements as well it should. So what happens is different movements get activated. They go to this part of the brain. They should normally be shut off, but that part of the brain doesn't work as well, so this movement slips through. And if that happens a few times, it's sort of a habit gets started with that movement. And then that goes for a while until something in the environment happens, we think, and then some other movement kind of takes its place. So the way CBIT works with that is what we're trying to do when the patient is actually seeing the therapist is we're not just treating each tic. What we're doing is teaching the child and the family how to treat tics in general. So when a new tic starts up 8 months later, the parent knows, well, here's a new tic. Son, why don't you and I sit down and figure out, given what we know about CBIT, how can we deal with this new tic? And usually the parents and kids know exactly what they should do for a new tic, even though the therapist has never talked about it with them. And the therapist always tells the family that, hey, if a new tic starts that you can't figure out, you come back, we'll have a little booster session, and we'll send you on your way. So what we're trying to do in CBIT is to teach them in general to learn how to manage tics effectively.
All right, and might autism affect a child's ability and success in the awareness part of this therapy?
Yes, absolutely. It could definitely affect awareness of the premonitory urge. They may have a harder time noticing the urge. Sometimes it's true, sometimes it's not, though. And sometimes, you may just have to be, as a parent, more direct. Okay, you're ticking. Now let's make sure you use your competing response, all right? Because the child may not be aware of the urge as much, and they may need more support from the parent.
Right. And can you share more about the decision to seek this treatment? If a child finds the tics annoying, is efficient, we went over that, but are there other options that outside of CBIT?
Sure, there are a number of options. So, the first option is just to educate the family about tics and say, hey, if this doesn't bother you, don't worry about it. That's option number one. Option number two is behavior therapy. Option number three is there are lots of different types of medications that can be used to manage tics. There are usually a couple classes that are used. Alpha-2 adrenergic agonists are one. Those are like clonidine and guanfacine. And then there are what we call atypical neuroleptics like risperidol would be another one. In kids, it isn't used very often, but traditional antipsychotic medication like haloperidol could be another one. Haloperidol, for example, is really effective in knocking out tics, but there are a lot of side effects that parents don't usually like. And then, when you get out of medication, There are things like taking Botox injections into the area of the body where the tic is. That's a little more experimental. In really, really, really severe cases, there's something called deep brain stimulation, which is basically like a pacemaker that you put into your brain that delivers little electrical signals to sort of normalize, regulate the functioning of the part of the brain that's involved in Tourette's. Again, that's usually for the most extreme cases where everything else has failed.
All right. And when it comes to educators, are there things that can be done in the school to support the CBIT approach?
Absolutely. There are definitely things that the schools should get in, that the schools could help with, but I would only suggest that that be done with consultation from the child's treating psychologist. I don't. Schools sometimes will get in a situation where they want to be the therapist, and maybe the parents don't even know what's happening, and that's not a good place to be. So I would always do any kind of school involvement. I would make sure it's done with requests from and consultation with either the parent or the child's therapist directly.
All right. And I think we're pretty much getting to a close here. Let me just do a quick browse here. Is it possible that a child can develop tics after a head injury?
Sure, it absolutely is. And if that happens, I mean, if the child has no tics and there's a head injury and then the child starts ticking, that's definitely a quick trip to the neurologist, I think.
Okay. And how would you suggest finding a good therapist who knows about CBIT?
Okay, so there are a couple different ways. The TSA has a program called the Behavior Therapy Institute, and what this is a list that the TSA holds. So you just call TSA, and they can tell you if there's a therapist that's been trained in your area. And what we try to do in that is these are therapists who come in. TSA has trained them specifically. They've gone through a training. TSA kind of supports teaching them behavior therapy. And what we do is we do a 2-day full training with these therapists, and then we have follow-up consultation with CBIT experts that these therapists will talk about cases with the CBIT experts, and the CBIT experts help them kind of through that. And so once the therapists have completed this training, they get put on this behavior therapy or BTI list that you can call TSA for and try to get people in your area who have been through the BTI. There are probably about 150, I'm guessing now, that have been through the BTIs around the country. So that's probably the way you can go with the most confidence of having a therapist who really understands CBIT. You know, if you can't find a BTI person in your area, one of the things you can do is go online. You know, we have the therapist manual. It's called, actually I don't remember what it is. I wrote the book and I don't remember what it's called. But online you can see a therapist guide for the CBIT treatment. And you can show a local therapist who's an expert in behavior therapy that guide, and they might be able to pick it up and figure it out if they need to. We're also in the process, colleagues and I are trying to develop an online self-help treatment for kids that's based on the CBIT module or the CBIT manual. It's not ready yet, but we're working on doing that, and that will be something I think that can be useful potentially for people who don't have access to a therapist in their area. So we're working on trying to get other avenues for children in terms of being able to access CBIT.
All right, and this harkens back to a couple other questions, but just to reiterate again, I think it's so helpful about CBIT working with teens when they're going through puberty, and that the tics will increase and change, and early teens, anything that again, focusing on one tic at a time, perhaps. Any other suggestions?
No, I mean, I think, teaching the teens to notice in their environment what makes their tics worse, and then helping them brainstorm, like, what can we do to change this environment a little bit to make your tics less likely to happen? How can you predict when they're coming? And if you can predict when they're coming, maybe we can teach you some skills to cope with the situations that make those tics worse so they don't happen so much.
So with all that said, in addressing the environmental factors and the waxing and the waning, how can this viewer is wondering how he can be certain that the CBIT is working?
Well, the way we did this, a couple ways to look. How can we be confident that CBIT works? Okay. Well, first of all, it won't work for everybody. But what we did in the study is we compared supportive therapy, where we taught kids about Tourette's and then provided them supportive counseling across the same amount of time as we did the CBIT group. So we put people into either supportive therapy or CBIT, and we followed them all for 8 weeks. And what we know is that CBIT beat the supportive therapy, was more successful than supportive therapy. Had waxing and waning been the explanation for the improvement, then the supportive therapy, which occurred over the same amount of time as CBIT, would have gotten just as much benefit as CBIT, but CBIT beat it by about 3 times the amount. So we're pretty sure that CBIT, any gains that you get from that, is not just due to waxing and waning. It's not just due to paying more attention to your tics or anything like that. There's something about the treatment itself that's making the gains happen. Now, CBIT, when you do it, the truth is, if it's going to work for you, it's going to work pretty fast. You'll notice within the first week of working on the first tic that tic goes down pretty dramatically. When the treatment's going to work, that's the kind of response you'll usually see.
All right. And here's a question that you stated that there's no cure for TS, but if a child only has tics and doesn't have TS, will the tics go away with CBIT?
Well, that's sort of an interesting question because TS is tics. That's all it is. So you've got motor tics and vocal tics. That alone is TS. All right. Now, sometimes kids will have other things like ADHD with their tics, OCD with their tics, and sometimes people think that must be TS, but TS really is nothing more than motor tics and vocal tics. If you look at our diagnostic manuals that we use to diagnose conditions, Tourette's is diagnosed when you have at least two motor tics and one vocal tic. It says nothing about ADHD. It says nothing about OCD. And so when I say TS, I mean everything. I mean kids with tics. I mean kids with tics plus OCD plus tics with Tourette's or tics with ADHD and so on. Kids with TS, their tics are, I think, as likely to go away as the kids with just motor tics or just vocal tics.
Right. And finally, Adagate, what is the best thing to tell teachers, getting back to the extended environment, to make them understand CBIT and to create a tic-neutral environment?
I would say to the teachers, the child's tics are something you need to ignore as much as possible. The only time you need to intervene, and we'll talk about how to intervene, but the only time you need to intervene is if the child's tics are actually inhibiting the learning of other children, okay? So the only time you'd need to get involved is if the tics are inhibiting the learning of the other child. Now, the tics could be inhibiting the learning of the child with tics, and that's one of the reasons we try to manage the tics. So we're not talking about that. But the teacher, we would ask them to, again, ignore the tics. If the child is doing tics in a way that's very disruptive to other kids, then we would work with the teachers to figure out ways that we could keep the child in the environment, meeting all of their responsibilities as a student, but do so in a way that would minimize the impact of the child's tics on the other kids. That's really, those are the kinds of things we'd be working with the teacher on. But the biggest thing is, don't treat this child any differently, if at all possible, than the kids without tics. And make sure you hold every expectation to the child with Tourette's as you do the children who don't have Tourette's. Understanding as a teacher that how a child with Tourette's meets his or her responsibilities in the classroom might be a little different than how a kid without Tourette's meets theirs. But again, the expectations of what should be expected of the child should be very consistent.
All right, Dick, and I will have us wrap up on this one last question. I also want all the viewers to know we have your questions that were in queue. We'll look at those, and feel free to contact the TSA with any other questions regarding this. And here it is. How often and how long does a child normally see a CBIT therapist to develop and follow a program along with family support?
Okay. So the way our CBIT protocol is written, we have 8 sessions over 10 weeks. Okay, so you would go for 6 weekly sessions, about an hour, hour and a half apiece, and then every other week for a couple weeks. Now, I always say to therapists I'm training and when I talk to parents, it's like, that's just a guess. We ask for 8 weeks. Sometimes you may only have 2 tics that you really want to deal with, and you can be done in 3 or 4 weeks. Sometimes you might have a whole lot of tics, and you might need 20 weeks. We just, we don't know. We let the child's tics tell us how fast or how slow we have to go. But generally, we look at about 8 sessions over 10 weeks.
All right, I want to thank you, Dr. Woods.
Thank you.
And I want to thank all the folks who are online as well as those who will be viewing this in our archived version. And please do click on our survey. It will help us. It will help you. And once again, thanks for attending this TSA webinar, and our thanks as well to the CDC.